how. So at this time, I'd like to send it over to Dr. Rachel Peterson. Rachel, the floor is yours.
Thank you so much. So I'm Dr. Peterson. I'm a assistant professor in public and community health sciences, and I'm very thrilled to be presenting today's speaker. Before I do want to provide a little bit of context about weight bias in public health, which tends to be a little bit of a blind spot. I personally first became aware of weight bias about 10, 12 years ago when I conducted a series of online tests interrogating my own implicit biases and found that weight bias was my own largest implicit bias. And so as I started to think through my own beliefs and perceptions, I also simultaneously started to think through the viewpoints and practices of public health and came to realize that as a field, we have uncritically adopted a biomedical perspective of weight, and that's not always to the benefit or health of our communities that we're working in. So I'm very thrilled today to present Miss Kat Hepburn, who is in her final semester of the MPH program in Community and Health and Prevention Sciences. This talk is part of her work in an independent study that she really conceptualized last fall. And I'm pleased to say it gained a lot of traction. And as other students learned about it, we now have 3 graduate students and 4 undergraduate students all pursuing the various independent projects under this umbrella of weight bias in public health. And so I'm very thrilled for Kat to share what she's learned so far as part of this independent study. And I will turn the floor to you, Kat.
Thank you, Rachel. So good afternoon, everyone. Thanks, Dr. Peterson, for the introduction. As she said, my name is Kat Hepburn. I use she, her pronouns, and I'm a candidate in the MPH CHIPS program here at the University of Montana. This presentation is partially in fulfillment of an independent study course and is titled Recognizing Anti-Fat Bias, Navigating Toward Inclusive Public Health Solutions. So the learning objectives for this afternoon, this brief period of time we have together, are I'd love for if you can walk away knowing what anti-fat bias is, how the bias impacts people within the framework of the socio-ecological model, if you can know how public health plays a part in perpetrating this bias, and maybe if you walk away with one way to intervene for the improved health of the population. I'm going to provide you with quite a few, though. I think it's important to talk about positionality when we're going to talk about this kind of topic. So for me personally, I'm a mid to large fat, queer, cisgender, neurodivergent white person, and I have multiple eating disorders and history of eating disorders. I was also raised by fat, college-educated parents who are actively involved in their own internalized anti-fatness. I hold a bachelor's degree in psychology from the University of Montana, and I'm an MPH candidate at the University of Montana. My goal is to use my privilege, education, and lived experience to disrupt spaces that are accessible to me, but might not be accessible to fatter individuals, those with less class privilege, or people who don't have the privilege of presenting as straight or presenting as white. I'm also a fat studies scholar, and so as such, you'll hear me use the word fat. Sometimes I'll say higher weight or larger bodied. I'm not going to use the words overweight or obese unless it's in the context of the literature, and that's how the literature presented it. Those words are pretty medicalized and othering, frequently considered slurs among fat individuals, and we can talk about that later if anyone wants to. So how do we define stigma? I'd love for, if you can, or if you have any ideas, to pop in the chat or unmute yourselves and tell me, like, what do you think stigma means or what do you think bias means? Yeah, negative associations. Yeah, good chance. Shame, yeah. Negative plus shameful, yeah. Thanks, Kimber, for sure. Seeing people as less than. Thank you, Carrie. Yeah, so all humans have a natural tendency to make assumptions based on characteristics such as race, ethnicity, gender, sexual orientation, disability status. When those assessments are unconscious, they're called implicit bias. And implicit biases are often triggered involuntarily. They often don't reflect our declared core values or beliefs. But when those attitudes, beliefs, and feelings about people or a group of people serve as motivation to consciously discriminate and marginalize, that's explicit bias. And explicit bias is also known as stigma. So stigma defined as attitudes, stereotypical beliefs, and or feelings about people or a group of people that can motivate one to consciously discriminate and marginalize. And stigma can have devastating health impacts. It increases suffering, diminishes health, is correlated with numerous adverse health outcomes, particularly among those who are disadvantaged to begin with. So I use the term anti-fat bias. It's the most accurate and active name for the bias. Weight stigma is totally fine to use. It's just a little bit more passive, but you might hear it called other things like fat stigma, anti-fatness, weight bias, or fat phobia. Fat phobia is not one that we really use in the fat liberation space anymore. It's not a phobia. So that usage minimizes what a phobia is, which is very real. So the word fat phobia kind of unintentionally places stigma on mental illness. So paints mental illness as a choice. Like I choose to be afraid of fat people, but that's not what it is. But anti-fat bias is stigma attached to perceived, actual, or contextual fatness. It's comprised of ideologies, practices, and systems that mark fatness as an undesirable, deviant, or inferior embodiment. And we can understand it as a social determinant of health. So it's a form of prejudice and discrimination based on one's weight or the size and shape of an individual's body. Unlike many forms of bias, such as those against racial minorities, it's bias against people in larger bodies is often explicit, overt, and rarely challenged. It's pretty widespread and accepted, including in our field of public health. And there's a perception that weight is a matter of personal responsibility. Thus, mere existence of a fat person represents a moral failing, right? And that bias is getting worse. As of 2019, the lead researcher in Harvard's implicit bias test says that anti-fat bias is the only bias that is getting worse over time. It's not only important but pressing to be aware of the prevalence of this issue and the manifestations that there are. And I can't begin to express the breadth of this issue in the time that we have together today. But a helpful way that I'd like to look at it is the forms that anti-fat bias takes using the socio-ecological model. For those of you who are not public health folks, I don't think this is a difficult model to understand, so don't be worried. So this is a socio-ecological model. This particular one was developed by myself and my colleagues in this independent study we're taking with Dr. Peterson. And this represents the intersections of individual, interpersonal, and institutional levels with anti-fat bias. And we're going to break these down individually. So at the individual level, there are primarily negative health impacts in the form of mental health, physical health, and eating disorders. Studies done by Hatzenbuehler and colleagues have demonstrated that perceiving any form of discrimination has been shown to be associated with major depression and generalized anxiety disorder. Even in the rare instance that individuals lose a significant amount of weight and are removed from a stigmatized group, they experience the psychological effects of weight stigma still. And specifically in this study, the people who were formerly overweight were at a greater risk of any anxiety disorder, any depressive disorder, and suicide attempts than those who were consistently normal weight and those who were overweight the entire time. Research also indicates a robust relationship between perceptions of weight discrimination and the prevalence of substance use disorders. And adolescents who experience anti-fat bias report sadness, depressed mood, and fear, and have increased risk for psychological distress, disordered eating behaviors, physical activity avoidance, and lower levels of sports participation. In physical health effects, I mean, there's substantial, but a publication by Sutton in 2015 revealed weight discrimination is associated with an increase in mortality risk of nearly 60%. The association between mortality and weight discrimination was generally stronger than between mortality and other attributions of discrimination. In addition to its association with poor health outcomes, weight discrimination may shorten life expectancy. The experience of weight discrimination has unique aspects that increase mortality risk that are not shared with other attributions. For example, the greatest perpetrators of weight discrimination can be loved ones who would typically provide social support in stressful situations. But when instead of being the support that buffers stress, those others are the source of stress, it can have negative impacts. In addition, given that weight is largely perceived to be controllable, unfair treatment because of body weight may lead to feelings of shame because of the perception that people should do something about their weight. And we touched on this a little bit, but with eating disorders, emotional dysregulation and experiencing anti-fat bias are both significant predictors of disordered eating. Dr. Virginia Solsmith says, the most dangerous way that anti-fat bias impacts the health of children, especially adolescents, is how it results in the misdiagnosis of eating disorders in kids in bigger bodies. Doctors know to look for eating disorder red flags in thin, white teenage girls, but they are much likely to notice these issues in other genders, other races, and in kids with higher BMIs. And they're likely to praise disordered behaviors like skipping meals and overexercising when they do come up. According to NHANES, between 2013 and 2016, 38% of adolescents aged 13 to 16 tried to lose weight. And that might be harmless for some people, but replicated studies have shown that teenage girls who diet at a severe level are 18 times more likely to develop eating disorders than those who did not. And eating disorders have the second highest mortality rate of any mental illness. So not only does the experience of anti-fat bias predict disordered eating, the anti-fat bias of medical providers delays or prevents eating disorder diagnosis and treatment. So then the interpersonal level, there are a few things to look at here. Weight-based victimization is one of the most common and frequent forms of bullying. A large systemic review of studies on weight bias in educational settings revealed the presence of implicit and explicit bias among teachers, as well as the belief that children with obesity are a burden and have control over their body weight. Also identified is the perception among educators that fat students are more likely to have academic challenges. Fat adults also report anti-fat bias at the gym, which is associated then with negative attitudes toward the gym, maladaptive coping behaviors, weight bias internalization, and poor self-reported physical and emotional health. So that experience in a space meant to improve one's physical health creates a barrier to participation in movement. Minority groups and the poor are the most likely to be targeted and penalized when the state takes punitive approaches to obesity by, for instance, imposing sin taxes on junk food or charging parents of very fat children with child abuse. Here's the thing that I know so much about, healthcare provider bias or medical trauma. So weight stigma is incredibly common among healthcare providers. A survey of more than 620 primary care providers found that 1/3 of them viewed obese patients as weak-willed, sloppy, and lazy. And more than half of them viewed their patients as awkward, unattractive, and non-compliant. So access to evidence-based and bias-free healthcare is incredibly important if we're going to provide strive to health equity. Fat people are less likely to receive fair healthcare, including preventative services and screenings, due to these attitudes by healthcare providers. And then that causes fat people to avoid seeking care. Fat patients are being stigmatized by their healthcare providers. It results in poor care. And then if you're able to move past that fear of being judged, and get the courage to seek the care, it's often futile. Once face to face with providers, the situation generally devolves into a diagnosis of fat. So some anecdotal quotes about interactions with healthcare providers include, "I knew your problem before I even saw you. All I needed was to see that you weighed over 300 pounds to know why you're short of breath," as the greeting Susan received as the pulmonologist walked into the exam room. "Roberta's doctor told her lose the weight. I have no idea what is causing the numbness in your legs." Lauren muses, "As a fat woman, any health problem, however temporary or seemingly unrelated to body size, is put down to my weight." Additionally, and we'd have to go into quite a bit here, but we can look at social media, romantic and platonic relationships, experiences with colleagues and at work, violence and harassment, and representation in media. But for the sake of time, can't get into those, but know that in each of these interactions and types of relationships, there is the existence of weight stigma and the effects of that. So at the institutional level, anti-fat bias can be experienced through physical inaccessibility, weight surveillance and environmental messaging, and BMI-based clinical policies. So physical inaccessibility, access to care means that when you walk into the door of a doctor's office, you can fit in the chair without hurting yourself. You can step on a scale that will weigh you. You can sit on the exam table comfortably in a gown that fits, have your blood pressure taken with the correct size cuff, know that you're receiving a vaccine with the right length of needle, know you can get imaging done at your local hospital, and so on. On college campuses, like the University of Montana, fat students often find themselves in physical pain and unable to learn due to spaces that aren't built for them. Yet college campuses don't invest in upgrades. Too small desks, booths and dining spaces with unmoving tables, and narrow hallways are all prevalent on college campuses. And when fat students are shown that they're unwelcome in learning spaces, their academic performance and mental health suffers. Utilizing transportation is a nightmare for fat people. Airplane seats are shrinking, and rather than pressuring airlines to prioritize passenger comfort over profit, many thin passengers take their frustration at being crowded out on their fat seatmates. To keep our neighbors calm, fat people contort their bodies into pretzels, determined not to take up more space than we can for hours at a time, resulting in injury. Additionally, each airline has their own unique passenger of size policy. Many of them require fat individuals to purchase 2 seats, even if there isn't a second seat available, and even if those seats aren't next to each other. So just unfairly taxing fat people, but not giving them any more space. Fat scholar Aubrey Gordon says, "Since these policies vary so much, fat travelers experience anxiety about flying, wondering when will we be allowed to remain on our flight, narrowly escaping detection. When will we be asked suddenly and without warning to pay the day of price for an additional seat, even if one isn't available? When will we be escorted from the plane to be watched by hundreds of our fellow passengers' prying eyes?" Weight surveillance. So the most visible example of bias in schools occurs in the 25 states where schools are legally required to monitor students' BMI. And in the 11 of those states, they send a BMI report card home to parents. Advocates of the BMI report cards believe that sending these report cards home to parents increases or will increase their choices to consume healthy foods and increase exercise. But there's a lot not being considered here, including measurable harm that it does to children. The experience of being weighed in public is traumatic. And then having a report card sent home to parents can create feelings of shame and stigma in children. And additionally, we don't know if children are experiencing violence in the home. And a lot of the time, if their interpersonal relationships have negative regarding weight, and then you send home a report card, there's a risk of actual physical harm to children. Employment discrimination. There are only 2 states, Washington and Michigan, and 1 city, New York City, which just passed this, in the US where employment discrimination based on weight is illegal. The other 48 states Fat people can be fired or denied employment simply due to the size of their body. BMI-based clinical policies. So the BMI was created in the early 19th century by Adolphe Quetelet, who was an academic with experience in astronomy, mathematics, statistics, and sociology, not in medicine. And he was primarily interested in creating a composite representation of the average man, which he believed was the ideal standard for a society. And so he used measurements of Western European men to develop the BMI formula. His work has been used to justify scientific racism for decades, but he was clear about one aspect of the BMI. It was not intended as a measure of individual body fat, build, or health. It was a way of measuring populations, not individuals. But the BMI today provides a clear way for healthcare providers to discriminate against patients and often overshadows health issues that would otherwise be identified in a thin body. So clinical policies. Weight loss is often a requirement of healthcare providers or insurance companies before they will provide life-saving surgeries or medications, frequently citing safety, although those same patients would be cleared for weight loss surgery immediately. For instance, obesity is considered, a contraindication to kidney transplant due to associations with adverse outcomes. Fat patients will be required to lose weight and delay transplant until they have decreased their BMI, although there's no data supporting improved patient outcomes with the pre-surgery weight loss. And from a cost-benefit perspective, kidney transplants have a lower cost than long-term dialysis. So the benefit of delaying transplant is not supported by evidence. It is merely supported by the BMI. But BMI criteria for joint replacement eligibility is marginally better than flipping a coin, and shouldn't determine surgical eligibility, but it does. Fat transgender patients are often denied gender-affirming surgeries when cisgender individuals do not face the same requirements. For example, a cisgendered person could easily get a mastectomy or breast reduction surgery, and transgender patients, if they're fat, it's just another way to withhold treatment from them. And fat people are almost never included in biomedical research. So medications that have been tested on thin people have not necessarily been tested on fat people. One of these, for instance, is the morning after pill, Plan B, is not effective in individuals over 195 pounds. I believe maybe it's less than that now. But there aren't studies like trying to improve that. So the war on obesity. This is really a product of public health. The National Institutes of Health declared obesity a disease in 1998, swiftly transforming people's body size into sickness. Headlines like "Obesity, a bigger threat than terrorism" peppered newspapers when U.S. Surgeon General Richard Carmona called obesity the terror within, implying a threat akin to terrorism in the years following 9/11. Despite a purported public health crisis, the federal and state programs that comprised the war on obesity were far from data-driven. And overwhelmingly, those programs and public messages hinged on shame and fear, kind of like a scared straight approach for fat kids, which we know doesn't work. A growing body of research shows the paradoxical impacts of that shame. The American Academy of Pediatrics, this is very recent, released a new controversial guideline recommending bariatric surgery for teens as young as 13 and weight loss medication for children as young as 8. Thanks to some celebrity endorsement, thousands of Americans have begun taking the prescription drug Ozempic for weight loss, which has caused a national shortage, leaving those with type 2 diabetes without a necessary medication to control their blood sugar levels. In America today, the medical and public health establishment have managed to transform what has traditionally been considered a vice, physical vanity, into that most sacred of secular virtues, the pursuit of health. So how does this show up in public health? Unquestioning use of the BMI, with its downstream effects impacting the general public via the media environment, healthcare guidelines, and health policy. So in media, the coverage of studies discussing obese people as a burden, a drain on the world, the country, healthcare systems, while some within public health have discussed weight stigma as a social justice issue, the framing of many articles on weight stigma still upholds this ultimate goal of eliminating obesity and, by extension, fat bodies as a public health goal. When we look at policy, we're talking about BMI screening, bullying, immigration policy, which does have some restriction on BMI, which I don't have time to get into today, but and BMI is a tool to justify disproportionate morbidity and mortality of BIPOC populations. So BMI as the tool by which obesity is determined has also been used to frequently by public health leadership and institutions to justify the disproportionate sickness and death of non-white fat people due to COVID-19, as well as help shift the onus of pandemic response from public health institutions and governments to individuals. So if you're fat, it's your fault that you're dying from COVID-19, not it's our responsibility to keep our population safe, regardless of their body size. Except at statistical extremes, BMI only weakly predicts longevity. Most epidemiological studies find that people who are overweight or moderately obese live at least as long as normal weight people and often longer. Fat people need COVID vaccines administered with longer needles to ensure the vaccine can reach the muscle behind the subcutaneous fat, but there's very little discussion of this prior to an awareness campaign by our late colleague and fat activist, Kat Pazé. And a lack of rigor and critical thinking in producing and evaluating evidence undermines the potential of social determinants of work by focusing on weight as the determinant and not bias as the determinant. So historically, most attempts to marginalize and shame a disfavored class of people has focused on a minority group of one sort or another. But the war on fat is unique in American history because it represents the first concerted effort to transform the vast majority of the nation's citizens into social pariahs. For public health, measuring bodies is a matter of exploring the risk of various body sizes and their associated chronic illnesses. Public health researchers have also explored fat people's associated experiences with weight stigma and negative health outcomes associated with it, although some of that research seeks to lessen weight stigma in order to encourage weight loss rather than reducing weight stigma based on the negative effects of weight stigma alone. Medical anti-fatness goes uninterrogated. Fat people face discrimination in education, employment, housing, but their differential access to resources has only recently been linked to health outcomes, and that is a social determinant. So it's well established that obesity is associated with increased risk for many diseases, but causation is much less well established. Except at physical extremes, high body mass is a very weak predictor of mortality and may even be protective in older populations. In particular, the claim that overweight, which is a BMI of 25 to 29.9, increases mortality risk in any meaningful way cannot be reconciled with the numerous large-scale studies that have found no increase in relative risk among the so-called overweight, or have found a lower relative risk for premature mortality among that cohort. In other words, the vast majority of people that are labeled overweight and obese, according to current definitions, don't face any meaningful increase for risk for early death. Epidemiological studies rarely acknowledge factors like fitness, activity, nutrient intake, weight cycling, or socioeconomic status when considering connections between weight and disease, but they all play a role in determining health risk. So consider weight cycling. Attempts to lose weight typically result in weight cycling, and those attempts are much more common among people in the obese category. Weight cycling results in increased inflammation, which in turn is known to increase risk for many of these diseases that we associate with obesity. So hypertension, insulin resistance, those can be increased, the risk for those increases with weight cycling. Weight cycling can account for all of the excess mortality associated with obesity in both the Framingham Heart Study and the National Health and Nutrition Examination Study, or NHANES. So it might be that the association between weight and health risk can be better attributed to weight cycling than adiposity itself. And then many common weight loss treatments generate particularly problematic confounders. So over-the-counter diet medications contain phenylpropanolamine and herbal ephedra, and those have recently been linked to heart attack and stroke. So the higher a person's BMI, the more likely they are to use those medications. If only 1 in 13 obese people were exposed to over-the-counter diet pills containing these medications, then all of the excess risk of obesity could be accounted for by increased diet pill use. So the causal links between high and low body mass and increased mortality remains still pretty speculative. So it seems probable that body weight, like height or baldness, is for the most part a proxy for many unmeasured variables. So from a public health perspective, the most significant aspect of such a conclusion is that most of these unmeasured variables, especially the lifestyle factors, are more readily modifiable than body mass. Promoting implicit assumptions of fatness as a modifiable individual health behavior and fat people as temporary. So this preoccupation with body weight dominates many health promotion strategies. There remains a heavy emphasis on behavioral approaches to obesity prevention in both health sciences curricula and in health service programs. Those approaches take a focus on the individual as the locus for change, making the client's personal responsibility for all aspects of their situation, as opposed to more environmental or socio-ecological approaches. And health practitioners are exposed to the same stigmatizing beliefs about obesity as the general public, and this influences their approach to care. Mass health communication campaigns aimed at changing health are usually aimed at changing health behavior. While many short-term weight loss intervention studies do indicate improvements in health measures, the weight loss is always accompanied by a change in behavior. So it's not known whether or to what extent the improvements can be attributed to the weight loss itself. Long-term follow-up studies document that the majority of individuals regain virtually all of the weight that was lost during treatment, regardless of whether or not they maintain the behavior change. Several recent studies indicate that the key to avoiding type 2 diabetes is not to try to lose weight, but rather lifestyle changes in regard to activity levels and dietary content that greatly reduce the risk of contracting the disease, whether or not those changes in behavior lead to weight loss. The claim that significant long-term weight loss is a practical goal and will improve health is almost completely unsupported by the epidemiological literature. One reason the hypothesis remains untested is there's no method available to produce the results that would have to be produced. So significant long-term weight loss in statistically significant cohorts in order to test this claim. So there's just no method that works significantly. It's particularly striking that studies have found health benefits associated with various levels of weight loss generally record no dose response. In other words, people who lose a small amount of weight or gain weight get as much health benefit from behavior interventions as those who lose a large amount of weight. There is a health promotion win. We can be proud of one thing. Some research suggests that some portion of the weight gain in the population is attributed to smoking cessation. So we have been really successful at getting people to stop smoking, but that has led to weight gain. So, and let's see if this video will show.
Weight gain is the sum of little things that add up over time. Choosing the escalator instead of the stairs, eating 2 helpings of dinner, And so on and so on. Ever wonder why you're winded or your joints ache and blame it on your age? Well, think about your weight. Imagine carrying a 10-pound bag everywhere you go. Just 10 pounds adds more than 30 pounds of force to your knees. So those achy knees might mean you need better heels. By realizing you're overweight and by taking control now, you may lower the risk of developing serious health problems like heart disease, high blood pressure, type 2 diabetes, gallstones, and some cancers. Losing just 5% of your body weight may also decrease the stress you're putting on your body. That means doing more of the things you enjoy without the aches and pains. It's the little things that make up the weight gain. And it's the little things that will help take it back off. Wouldn't you like to drop the weight and stop picking up more? Obesity happens 1 pound at a time. So does preventing it.
So, and that is health promotion at the federal level. So we are certainly victims of it. Yeah, I hate it too, Laura. um, so how else does anti-fatness show up in public health? Pathologizing obesity and pursuing, oh gosh, pathologizing obesity and pursuing obesity prevention, which is what we just saw, right? Obesity is this model that frames all fatness as interchangeable and pathological, and it justifies and propagates harm. When we approach fatness through this obesity lens, this biomedical lens, we're compromising the quality and range of scientific research on fatness and on weight stigma. Obesity research is consistently funded, but specific conditions are under-researched and undertreated, such as lipedema. Obesity prevention cues into this social construction that fatness is bad, fat bodies are bad, fat people need intervention. It doesn't meet ethical standards, and it prevents treatment of patients' actual concerns. So, put simply, it's commonly believed that people who are fat eat too much and do not exercise enough. However, substantial evidence suggests that that's untrue. The energy balance hypothesis fails to account for homeostatic evolutionary mechanisms, whereby when presented with energy deficits and the perception of famine, the human body will eventually slow its metabolic rate to maintain or gain weight, and may also send hunger signals to increase energy intake. Development of weight management interventions that fail to adhere to AFA's code of ethics. So intentional weight loss treatments have about a 95% failure rate. And I would argue that that does not adhere to an ethical standard of informed consent or non-malfeasance. When you prescribe something that has a less than 5% chance of succeeding, but don't share that with your patient, that's not informed consent, right? And then we know that pursuing intentional weight loss leads to weight cycling, and we've talked about all of the damage that weight cycling can do. And so we are really like underappreciating the risks of creating eating disorders, of creating negative health impacts. Public health policies which promote weight loss as feasible and beneficial perpetuate misinformation and damaging stereotypes, increase chronic stress, which contributes to negative health impacts on the population. So ethically, is what we're doing proportionally beneficial here? Does the good outweigh the harm when we're trying to get our population to pursue intentional weight loss? So ways to intervene, maybe some silver lining in all of this. On the whole, body weight might seem like a poor target for public health remediation, particularly in the absence of any safe or effective tools for weight loss. And many of the tools that are currently employed have serious side effects, which can include death. And so public health interventions designed to lessen the rates of obesity and overweight are striving to achieve a presently unachievable goal of unknown medical efficacy. So as public health professionals, how do we intervene? And I think these might go from easy to hard. So maybe walk away with one of these today if you can. So to the extent that body size is a risk factor, it is non-modifiable. So you have to treat it as such. Name anti-fatness rather than weight as the risk factor. The words obese and obesity are not neutral, even when you apply person-first conventions. So be intentional with your language. The word obese literally means to have eaten oneself fat. It's incredibly stigmatizing. Even when you're treating it as a disease, it just can be really harmful. So just be considerate with your language if you can do one thing today. Center fat people as the experts in our own lives. So we're a marginalized stakeholder group. Consult us on research and practice that pertains to us, the same way that you would do with any research that you're doing, particularly CBPR. Take ownership. Weight stigma ideologies, practices, and systems come from public health. So we have to know the harm before we can rectify it, right? Consider the effects of anti-fatness in your public health curricula on your students, especially your fat students. So obesity research is a great case study for the devastating impacts of poor methodologies, as long as those lessons don't occur at the expense of fat students' well-being. So don't present obesity research uncritically, and educate yourself on anti-fatness to support your students, which there are several professors in the Zoom room right now, and you're doing that. So thank you. Eliminate routine default use of the BMI as a variable in research. If it's not relevant, it doesn't need to be a variable. This is a hard one. Reject funding from entities and projects oriented toward weight management. I know that when we are looking for funding, we're usually just going to take as much funding as we can get for our projects. So this might be a difficult one to do, but if the project is geared toward weight management, I think about your ethical duty as a public health practitioner. Don't make it about fat people if it's not about fat people. So you don't need to use obesity prevention as a talking point or a benefit about an unrelated project. If your research is on food sovereignty or physical activity, make it about those things, not about the size of someone's body. And then investigate anti-fatness as a contributing factor to public health crises like maternal morbidity and mortality in Black people, food insecurity, those kinds of things. Find your allies, use your clout to speak out. If you have an MPH, if you have a PhD, your words have weight, no pun intended. So use your clout to speak out against that. And then if you can and you're interested, work to develop policy like supermarket development and food deserts, adjusting ag policy to increase planting and selling of fresh fruits and veggies, building communities with active, accessible transportation and physical activity in mind. As public health professionals, if the health of the population is our priority, we have to name and recognize that our profession is a large actor in perpetuating this harm so that we can begin to repair and reverse some of the damage. We can't assign our moral judgments to the majority of our population because we are the experts. We have to be willing to see the harms done and repair them. All right, thank you.
Great, thank you so much, Kat. If you want to minimize or stop your sharing so we can see, and if everybody wants to come on your camera, if you're available to come on your camera, and we will open it up for Q&A. Oh, I see Kimber has her hand raised.
Hi, Kimber.
For recognizing me, and Kat, thanks for your presentation. I wanted to start by commending you for your use of language. When you began, you referred to yourself and your fellow classmates in the independent study as your colleagues.
Hmm.
You also referred to yourself as a FAT Studies scholar.
Mhm.
I just wanted to tell you how much I appreciated that. Hearing that kind of language being embraced and used by one of our students made me very proud.
Thank you.
And beyond that, I was wondering if you could talk about if there is any connection between ACEs um, and body weight or BMI or complex childhood trauma. And if you do know anything about that, the study of that connection, what we can learn from that. So thank
Yeah,
you.
that's an awesome question, Kimber. As far as studies go or any of the literature, I don't have any of that information, but I'd be interested to learn more. And I think Jim is probably a good person to connect with on that too, with all of his knowledge of the ACEs. So I'll certainly reach out to him. I mean, I could speak on a personal note, but I probably won't do that here. But I do think the connection is anecdotally, I'll say the connection is there. But I would need to look more into that. Yeah.
Thank
Great,
you.
Laura, I see you have your hand up.
Yeah, Laura.
Hi, Kat.
Hi.
Hi. So I really, really loved your entire presentation and wanted to specifically comment on how you were able to communicate like just the lack of data we have in assigning health with fatness. And I am wondering if there's opportunity within our public health department space. I don't know a ton about this. I'm the dietitian on campus, as you guys know, to speak more to our interventional health people on this campus, like the folks at Curry Health Center, more directly, because I have tried to get that sort of information across before and am not able to do it as eloquently as the public health professionals, the MPHs on the campus. And I'm wondering if that type of work is happening or if there's opportunity to speak more directly with our doctors and our PAs and our nurses on this campus about it, even giving them this presentation. I just thought the way you got that data across was so well done.
Well, thank you, Laura. And I appreciate like it's really affirming to me to have a dietitian in the room and be like, this is good work. So thank you for being here. I think Rachel Berry, are you in the room?
Hi, yes.
You on the spot. Rachel, can you talk about your work with the as a wellness coordinator? Sorry, I lost my words completely. And your work with Curry?
Yeah, so I work in the wellness department as a peer health educator. Um, as of right now, we don't really do a lot of outreach around like nutrition and like weight bias, which is definitely something we're looking into getting more of. But I think that there definitely is some opportunity to maybe even have this presentation, if you would like to give it again, Kat, to the physicians that are on campus. Sorry, oh my gosh. But yeah, to give it to the physicians that are in Curry. I think that it's all really great information, and it could be really helpful to them.
Yeah. Thank you, Rachel.
Can I just add in too? So,
Yes, yes.
so Rachel is, one of our students in the independent study, and each student is kind of pursuing their own avenue. So Rachel is working with the wellness coordinator. So she's busy developing a training to help the wellness coordinators who have outreach with the students. Joya, who's here, is a physician in her home country of Bangladesh, and she's been in contact with Missoula Public Health to do more training with healthcare providers, starting at Missoula Public Health, but also reaching out to the hospital. So each person in the independent study is kind of pursuing their own independent work around this, but really with the goal of raising awareness. So there's a lot of public facing action coming out of this independent study, which I'm very proud of. Very motivated students. So
Yeah. Yeah. A lot of nice comments in the chat. Thank you, everyone.
All right, any last call for questions if you have any more burning questions? Great. Well, thank you all for coming today. I know there's a lot of the Confluence Conference going on, a lot of other conflicting kind of activities, and so we really appreciate your attendance. And thanks again to Kat.
Thank you.
Great job, Kat.
Thanks, Haley.
Rocked it. You rocked it.
I'm so proud of you.